there's a spot on the thing that says comorbidities, and I always look for them, and it's like.
I was like, because I was on renal before I started that OB back, and I was like, where's the where are their electrolytes? Why are people doing this? And I was like,
They might be on their way to unhealthy, but we don't have to
yeah.
I don't think it dims up front here, but there aren't any ultrasound slides, so I don't think we'll have to dim it very much. And I can probably move over so that people can see the slides better. Unless I don't know. Does that make it any easier to see the slides if I move back?
Yes. Thank you.
Okay. As long as no one plays jump rope with this thing, I think. Oh, it's Velcroed to the floor. All right. Very good. Okay. You can feel free to move the table if that makes it easier on you. So the topic is fetal breathing and body movements. And when you think about it, you think, can you really make a whole lecture about fetal breathing and body movements, really? But it's an important topic, and it actually used to be a full chapter in Creasy and Resnick. And it now is folded into a broader chapter on fetal health. But it's important for MFMs to know about this topic because we are often the arbiters of interpreting that biophysical profile, and understanding what's behind the fetal body and breathing movements is really important in that interpretation. And it's, maybe it's just a sign of me getting senile, but every time I review this stuff to do the lecture, I actually learn something new. So I don't know if it's me or if there's still stuff to be learned. Let me see. Do I have to? No. Good. Okay. That's just me. And then okay. So understanding what's going on really is based on understanding what the behavioral states of a fetus are. And the behavioral states in utero are sort of correlated to the postnatal sleep states, and that's what they've come to figure out. And we know that the behavioral activities probably have something to do with normal growth and development, because when they don't happen, normal growth and development doesn't happen, especially of lungs and the musculoskeletal system. And we've come to rely on these behavioral states to characterize the fetus as either healthy or not well oxygenated. And the emergence of behavioral state activity is related to the maturation of the brain. And this has been looked at in animal studies in particular. Let me see. Of interest, in the human, and we'll get to this a little bit later, they can only, we think the fetus probably has recognizable behavioral states probably at 36 weeks and after. Before that, there are times of a recognized behavioral state, but there's a lot of time, and there's a chart in here, where we can't tell what state the baby's in because it's not giving the right brain waves or those kinds of things. So studies were initially done in animals and looking at the cortical activity, eye movements, and the nuchal muscle activity. And there's states that correspond to non-REM and REM. As you know, the non-REM, there's very few eye movements, low activity. I got it. This is in my way. Absent nuchal muscle tone, so deep sleep. REM, where there's rapid eye movements and still nuchal muscle atonia. and awake state, where there's eye movements present or absent, and some nuchal muscle activity. And based on sort of, these are correlate with sort of the neonatal sleep states. There's the quiescent state, or deep sleep, where you have very stable heart rate that doesn't show much beat-to-beat variability. There's REM sleep, where you have the eye movements and more variability. This state, which some people say may or may not really be there, this is controversial, where it's supposed to be a quiet, awake state. And this is the awake state, where you can tell because the baby's having a grand time. There's looking around, the heart rate's all over the place, and there are accelerations. And just to make understanding that while there are some breathing movements in the deep sleep, they're more regular and not as frequent as in the REM stage. Baby peeing seems to happen with the change in state, and regular mouthing movements only occur during periods of quiescence, and that's how they distinguish what's going on. There are various studies on how much time the baby spends in various times, but regardless, we seem to understand that the fetus spends most of the time in REM. And this, depending on the study and the gestational age, it's hard to know exactly what they're doing. But we sort of, and these studies have been looked at, depending on what state they're in, how long does it take to get a sign of fetal well-being. So if you start in the quiescent state, it's almost a half hour till you can get your biophysical or non-stress test to be reassuring. And 44% fail to achieve a satisfactory score, and 88% of the time criteria for tone is not satisfied. In REM, it takes 5 minutes to get there, so it's really dependent on state. And at 36 to 42 weeks, no episode of quiescence lasted more than 38 minutes in 78 patients, but if normal is considered up to 110, some people say 120 minutes, because in babies who have had completely, crummy assessments, they have turned out to be normal with this going on up to 110 minutes. So this is the chart I was referring to in terms of gestational age. At 25 to 30 weeks, you can tell, non-REM and REM, but most of the time you can't tell what they're doing. As opposed to 36 and 40 weeks, REM still predominates as an identifiable behavioral state, but most of the time you can tell what they're doing. That it just seems to be a maturity of coincidence of behaviors that allow us indirectly to identify the sleep state of the baby. And the activity cycle seems to be shorter in the preterm and longer at term, although certainly this is variable. So with a hypoxia or IUGR, what happens? We don't think the electrocardiogram, so the brainwave activity, changes until the hypoxemia is severe enough to cause acidosis. And the percent spent in REM goes down. eye, limb, and breathing movements are decreased with a lesser degree of hypoxemia, and that's teleologically thought to be, well, it's conserving energy. If they don't move around as much, that's probably what's going on. And only marked decreases happen with acidemia. And with IUGR, there seems to be a delay in when these behavioral states show up. So there's a concern that with IUGR, perhaps there is a disturbance in the organization of the brain or delay in development. So when we look at the developmental changes in terms of appearance of these things, we can probably see tone very early in the first trimester, movement in the first trimester. They start to flap their little limb buds somewhere in there. Breathing movements can be seen, sort of at the transition between the first and second trimester, but they only become regular sort of in the mid-gestation period. And fetal heart rate accelerations associated with movement probably happen mid-gestation, and they're predictable at the end of the second or early third trimester. And number of movements per hour actually decrease between the beginning of the third and the end of the third trimester when they are observed by ultrasound. The patterns also change in that there's a longer duration of the cycle, as I mentioned previously. Body movements are evident during labor even, and there seems to be no decrease in body movements during the days before labor begins. With animal data, breathing movements, they were reported a really long time ago, and this is probably 40 now. I forgot to update that part because it's been a while. So they are, if you've ever seen breathing movements, they can be a single deep, what some people describe as a gasp or a sigh, or rapid and irregular. And when they measure these things with little tubes in the trachea and that kind of stuff, you have decreased tracheal pressure with a descent of the diaphragm and a tiny movement of tracheal fluid up and down. But it is associated with production of fluid and addition of fluid to the amniotic fluid. So when there is breathing, a lot more fluid comes out than if there is no breathing. There is a diurnal variation in breathing movements, even in animals. There's developmental changes as gestation advances, and breathing movements do seem to decrease prior to delivery, as opposed to body movements. And with short-term hypoxia, breathing movements decrease, but if acidemia does not set in, they return. There's a marked decrease with acidemia and a marginal decrease with IUGR. So what kinds of things control breathing movements? Certainly, we see this in our diabetics. Boy, you put that transducer down and they're breathing up a storm. It's probably because their sugars are out of control, and you don't even need an IV. They have high sugars. It's stimulating the breathing movements. And things you might predict: caffeine, elevated temperatures, catecholamines, cocaine, and surprisingly, indomethacin, theophylline, which we almost never use. Decreased fetal breathing movements, hypoglycemia, and the things you would predict: barbiturates, diazepam, and this is probably what is related to labor, prostaglandin E2. In the human, we think that the breathing movements are associated with the chemoreceptors that really control our breathing movements. When there's increased CO2, they increase, and when there's hyperventilation and lower CO2, they decrease. And in the last part of gestation, you see breathing movements quite often, so you're going to hit it most of the time if you look at them long enough. They are related to behavioral state, as we talked about before. And if you look at 30-minute intervals, very few of them will contain no fetal breathing movements. But apnea can occur up to 2 hours in healthy fetuses, as we all know, because we've sat there and waited for them to breathe when we're assessing their well-being. So we know that it's somewhat responsive to typical daily activities of the mom, so they are highest in the second and third hour after meals, probably when the baby gets that little surge of glucose. They seem to be increased overnight, so those biophysicals in the middle of the night seem to not take as long, and they do go down in the labor and preceding labor. So when we look at breathing movements and we're assessing fetal health, if breathing movements are not present, you can probably bet your allowance that they're probably falsely not present because of early gestational age. This is, I guess the only other addition this says is that alcohol and methadone also decrease fetal movements, surprise, surprise, and other tocolytics also increase fetal breathing movements, the beta mimetics. Body movements in the animal also are... Yeah.
That often found people have smoked to put in their baby has less of a breathing movement than when they haven't.
I thought when they did the animal studies, nicotine increased them.
Like whenever people come in, you have to say smoke before coming in and say yes, and then that's not next to next time. I don't know. Okay.
I mean, maybe they just need an infusion of nicotine. And then it'll be just fine. That's the difference between the animal and the clinical data. Okay. So we, as you can imagine, and as we have observed on ultrasound, complex movements tend to occur in clusters. The baby seems to have a little party and then rest, moving all around and then rest. And when they transition from one state to another, there seems to be more movement. And certainly when they're awake, there's a marked increase. There is increased activity overnight, so all those moms who say, boy, I lie down and go to sleep and the baby's moving. Well, for some reason that happens. Yeah. Because people looked with an ultrasound for a long period of time in studies. This is what people have looked at over the day. Volunteers. They've divided things up into half-hour periods and that kind of stuff. They actually are based on ultrasound studies.
When the ultrasound is done, it's the woman's the
That I don't know. I'd have to go back and read them.
It's very few people that ask
I don't know if it's positional or not.
Well, I'm just thinking
Yeah. I don't know if people have studied the difference in activity between the standing and supine state. Idea for a study.
Well, again, most people just don't stand. They're mobile.
Right.
Yeah, so if you take away ultrasound of a woman when she's mobile, if they move at times, then you're predicating the state that you look at movement.
And I would imagine that some of the modalities for measuring movement in the fetus would not work very well if the mom was also mobile. So that would be difficult. So it may be predicated on a maternal resting to be able to figure this out.
Yeah, so this was where I'm not certain about that state. It's under the auspices of how was it made.
Right.
Recumbent with no.
Well, if they were also recumbent during the day. Yeah.
Very
So.
few people live in recumbent position.
Correct. And I guess if we haven't, I don't know what the lighting was in the room either, as I guess has been an issue as well. Does that stimulate activity or not? All right. There we go. So, and when they can induce hypoxemia in the animal, certainly they see a decrease in the body movements. This looks like a duplicate. Anyway, we'll go over it. Last 10 weeks of pregnancy, 31 movements per hour. There's a clustering. Did I go the wrong direction? Maybe well, we'll skip that anyway. I already said those things. With body movements, there don't seem to be changes with IUGR. When they look at maternal perception of movement versus what is recorded by the ultrasound, some is undetected and some is recorded as being present when there is no movement. There's very few hours that go without any movement whatsoever, and certainly, as we all know, the ideal number of movements per hour is undefined. That 31 movements per hour is an average with a wide range of variation. So when it comes to the contribution to fetal growth and development, there is very little evidence, and but people are actually still working on this. We know what we know from animal studies and with circumstantial findings based on babies, human babies with anomalies, who, for whatever reason, didn't move or didn't breathe or whatever. So we know that if there are no breathing movements, there is decreased DNA content of the lungs, so they are smaller. And it's thought that the breathing movements oppose lung recoil and maintain expansion. And recoil results in the loss of fluid and eventual lung hypoplasia. And they did this in animals by, they did it in two ways. I think they ablated the phrenic nerve, and they also looked at temporarily paralyzing the phrenic nerve in animals to see what's going on. And why is they think that the breathing movement actually causes a distortion of the lung cells, which stimulates cell division and lung growth. When you just, the reverse, however, is not true. That if you don't see breathing movements, there must be lung hypoplasia because, or if there is breathing movements, there isn't lung hypoplasia because in the presence of lung hypoplasia, breathing movements still occur. And they think early on they may not be present because it takes a greater effort, and the very young or weaker fetus in the presence of oligo may not be able to expand those or to do what they need to do to decrease their diaphragm. But as in later times, as the baby is larger, they can actually show breathing movements. And if they, in an animal state, if they induce oligo and then put the fluid back, the reduction of lung expansion is reversible, and I guess that may be our basis for doing the amnio infusions based on that animal data. With body movements, we think that they contribute to the development of muscles, joints, and the brain synapses that sort of need to be pruned for appropriate neural activity. But on the molecular level, it actually seems to influence what myosin genes are expressed, the fast or the slow, and you guys probably remember that a whole lot better than the rest of us because you've actually seen that. And it has to do with stretch and muscle loading and pattern of activity and interaction of the muscle and nerve. And for example, even though this isn't body movements, but fetal breathing places workload on the diaphragm that influences expression of the myosin isoforms. And there's something called, I don't know how to, is that Titin? I don't know how to say it, Titin or whatever. this is a protein that is responsible for the elastic property of the diaphragm. And when they put neonates, preemie neonates, on mechanical ventilation, they lose this. And so the absence of breathing movements may actually, we're thinking, contribute to this. It's the activity of the diaphragm actually contracting. So, when we look at assessment of fetal health, we know that hypoxemia alters the cell function directly. It's partially a function of the duration of observation because of periodicity, but there's also diurnal variation, and the increased breathing movements overnight happen between 1 and 7 a.m. So the negative predictive value of having breathing movements, body movements, and NST is very high, either any one of them. And if you combine them, you don't get a better negative predictive value. But in terms of the positive predictive value, body movements seem to improve the positive predictive value of the biophysical for an abnormal outcome more than NST or breathing. And this is what we've talked about in terms of the biophysical profile is not weighted whatsoever. And there are probably things that are more important than others. And we'll talk about this a little bit more. So if you don't have body movements, you're in trouble. So the explanation is that when there is asphyxia, the fetus adapts and basically ceases non-essential activity to reduce oxygen consumption. And we know when you provide neuromuscular blockade, the oxygen consumption goes down. And this allows redistribution of the cardiac output to essential organs. And I guess the bottom line, however, is even that this process of adaptation may not compensate or sufficiently to allow the baby to survive, or to allow the baby to survive without damage. And Heather went over this a couple weeks ago. Certainly there's this gradual hypoxemia concept that the things that develop the earliest are the last to go when there's hypoxemia, and the first things to go are the things that develop later. And we know that breathing movements and reactivity are probably abolished less than 7.2, and tone and movement probably don't stop to a lower level. But there are holes in this theory, and again, always periodicity, always CNS depressants, and this can be a red herring, because if you see fetal breathing alone, even though other things are not present, it can be a warning sign, because of in postpartum pregnancies and diabetes, it can be a very bad sign. Unusual presence of continuous fetal breathing movements with complete absence of all other behaviors may indicate acidosis. So when you say the biophysical is 2 out of 10, what's present may have a lot to do with how bad the baby's off. And it may be distinguishable by the rate, because the normal rate of breaths are relatively slow. And I think the normal rate goes up to about 70 or 80 per minute. But this abnormal continuous breathing is a much higher rate, and perhaps all stimulated by the hyperglycemia. So specific clinical situations, betamethasone, what happens? So there is decreased breathing and movement associated with given betamethasone. It causes decreased amniotic fluid volume, but not anything low to measure. It may be because of the reduction in fetal breathing movements. And the thought is that it works centrally, and it's not something that is related to glucose or anything else that we can necessarily measure. But I don't think anybody's stuck probes in there to figure that out. You know, I don't remember that. I had the same question myself, and I think it's 48 hours, but I don't remember. Does anybody else ever remember reading this stuff? I thought it was 48 hours that you could see the difference from steroids. Certainly in the first 24. And there are several studies out there. I should go back and look at this Jackson one, because when I looked at this, I had the same question, and I didn't have a chance to pull out my files. There it says they're suppressed by nicotine. Dr. Flick, figure it out. I don't know why. So, yeah, I don't know. It's different than the animal, I guess. I don't know. So, I stand corrected.
Maybe it's a timing. You have it right away versus the
Yeah.
effect.
Yeah.
Maybe they're pumping the animals with it right at the time they're looking at it.
I don't know.
So the time they smoke to wake them up,
And fasting can certainly be associated with fewer breathing movements. But that's always a tricky situation. It always irks me clinically when a few places where they don't have obstetrical units will have the radiologists do their biophysical profile, and some of them have policies where I have worked that they won't do the biophysical profile unless the mother ate. And on the obstetric side, we're ready to cut if the biophysical profile is bad. And here they're worried about a tracing, and a biophysical gets ordered, and the radiology department will refuse to do it unless the mother has a full meal. So it's a very interesting situation. So it just they just need to be educated is the main thing. But don't be surprised if you run into that at other hospitals. So in labor, as we discussed, there's decreased fetal breathing movements with rupture of membranes. We can see during the labor, fetal breathing movements decrease markedly over the course of labor. And then this is from Dr. Amon, way back when, I guess, did you do this as a fellow or post-fellow? Post-fellow. So when they looked at use of Cervidil, fetal breathing movements went from 60% at baseline to 0 at 12 hours, and fetal movements went from 100% at baseline to 25% at 12 hours. And it correlated with the prostaglandin, and with the control group getting oxytocin, there were no changes in activity. So it definitely appears to be a causal drug-related effect. With malformations, there are a variety of things observed when there are musculoskeletal lesions, absent fetal movement, GU, absent fluid tone and breathing movements, CNS abnormalities, tone and fetal breathing movements. Thoracic may have absent breathing movements. Multiple malformations, you may see absence of all four. With GI and cardiovascular malformations, there don't seem to be any changes. So it may be related to development. And I think in interpreting biophysicals in those patients, just like Dopplers can be changed with certain abnormalities, certainly the biophysical score can be changed with certain abnormalities. With magnesium, when they look at it acutely, there seemed to be no change in the biophysical score. But no one's really looked at anything after 24 to 48 hours, and some patients are on MAG for a longer time. And there's this other report of once you reach a therapeutic level of MAG, there may be more fetal breathing and non-reactive NST, but it may also be in patients who've got steroids, so it's hard to know if it's controlled for those, which we know can decrease those parameters. With ruptured membranes, certainly there's an increased likelihood of non-reactive NST, absent movements, and decreased fluid volume. There are some studies, primarily from Vinceleos, that show that the first sign of intra-amniotic infection may be a non-reactive NST and loss of breathing movements. It was a retrospective study, and other people have actually said that it's probably not true. Other people have countered it and said that it really has no predictive value and low specificity for infection. So controversies in the literature. Can you use vibroacoustic stimulation to wake up the baby? So no one's done a randomized trial. And it's mostly done to elicit a reactive tracing, and we know that works. We know that the baby can hear, but the earlier the gestation, the louder the stimulus has to be. They seem to respond to lower frequency noises better than high frequency noises. And we don't know if it's the vibration or the sound that makes the difference. It's hard to separate those two. And after stimulation, you may actually see less breathing movements and certainly more irregular breathing movements because of the wakefulness state. After vibroacoustic stimulation, it only increased the number who had breathing movements by 5%. Things like shaking the baby, IV glucose have really not been studied in trial situations. Then I looked more into the hiccup controversy, this was a question and that Heather addressed the other day. So the articles on hiccups are really old. They're in the 80s and the 90s. I think there was one from 2007. I'll go over this. So the quote, the citation in Creasy is in their table that hiccups count as breathing movements, but it's unreferenced, as Heather mentioned. And there have been no recent studies. So what we know in animals is that when you instrument baboons, hiccups are very different than breathing movements in terms of what they look like, how much negative pressure they generate, those kinds of things. And their characteristics are so different they can tell the difference between hiccup and breathing. And they didn't occur at transition in behavioral state. They seem to occur no matter what. They seem to occur cyclically. And in the pig, they described hiccups as stereotyped events, again, distinct from breathing. And they also conceded that what controls fetal hiccuping is really unknown. So it hasn't been well studied. In humans, what do we know? That hiccups probably happen a little earlier than breathing movements. They are the predominant diaphragmatic movement before 26 weeks. This is all, waving the arms. They're a programmed isometric inspiratory muscle exercise of the fetus in preparation for breathing, but that's a lot of hand waving. Who the hell knows why they're there? They seem to be more closely related to suckling and gasping rather than to breathing. There's a developmental trend, as there are with many behavioral things, but with hiccups, they seem to increase with gestation and then decrease as gestation advances. They are measured by something called fetal biomagnetometry, which somehow is able to detect the muscle movement. when they look at the relationship of hiccups to fetal heart rate tracing, it does seem to affect the fetal heart rate tracing in the last trimester. And I was unable to pull the articles to see if they had any tracings to show me what they meant. When some people have done Doppler studies on the uterine artery during hiccups, and this was not just in one baby, in several babies there was intermittent, decreased, or reversed umbilical artery blood flow that coincided with hiccups. So that was a new tidbit, I guess, that we have to pay attention to. If they have reversed flow and they're hiccuping, we have to wait till they're no longer hiccuping to decide if it's a problem.
I imagine it would be for every heart cycle.
I don't know. I guess it depends on the frequency of the hiccup and the frequency of the heart rate. Hiccups do not seem to be related to glucose concentration, as we know from fetal breathing movements. And when they looked at what happens with hiccups with stimulation, doesn't seem to make a difference. If they scare the hell out of them with the with acoustic stimulation and they jump up and they pee and everything else, it doesn't seem to affect their hiccuping. If anything, they're a little less present after being stimulated with sound, but not statistically different. In all non-reactive NSTs, hiccups were absent, if that's any benefit. So it may be a measure of fetal well-being, but it's not necessarily, we don't necessarily know how to rely on it. And they certainly have been reported in babies that are really gorged and having seizures and that kind of stuff. They can see hiccups happening. So it's not necessarily reassuring. There are certainly plenty of reports of bad babies having hiccups. So the bottom line, when you're interpreting fetal breathing and body movements, be mindful of the clinical context. The drugs, the labor, the ruptured membranes, whatever else is going on. Any other kind of external influences, and I guess that would include whether the moms are supine or whether it's light or dark. Consider the gestational age and the developmental or maturational status of the fetus. The behavioral state, and fetal hiccups, while generally reassuring, are not studied well enough to determine their predictive value. And I think that is the bottom line. That's the bottom. Any questions? Yes. Go ahead.
I have two kind of specific situations. With the diabetics, which of these is the most reassuring, since they usually have the fluid and they can obviously be breathing all the time? Like if it's a 6 in a diabetic. And
My answer would be, unless they have vascular disease, you only need to get ST. The biophysical is pretty worthless because of that. They have breathing and fluid for reasons unrelated to fetal health. And so probably fetal movement and the non-stress tests are going to be your best bets. With vascular disease, I think looking at, you have to worry about placentation and that kind of stuff. So even our antepartum guidelines will indicate that in diabetics without vascular disease, twice-weekly NSTs are the basis for monitoring. Excuse me. Some of our attendings like to look at amniotic fluid volume because it may be reflective of glucose control. They can lie about their sugars on their piece of paper, but the polyhydramnios doesn't lie. Is what the thought is. So maybe a modified biophysical with just fluid and NST would be useful in that situation.
And then with methadone patients, a lot of times their NST is kind of stress reactive, but don't ever have anything concerning on it. It'll be moderate. Their D cells, maybe have 10 by 10s or 12 by 12s or 15. Do you think we should be doing BCPs in those patients?
Also, on our antepartum guidelines, methadone, or let's call it narcotic drug dependence, is not an indication for antepartum testing. so they don't even need antepartum testing. And Dr. Scheichen will be the first one to tell you, but if they have other indications, like anybody else, they would need it, and then you have to just suck it up and figure out the contribution of methadone. But they probably are not any more at risk for fetal death than anybody else. And they do offer a challenge, and they to interpret, and they sit in that NST chair for way longer than anybody. You know, they take up 2 spaces that two other people could use.
And the ones upstairs will get like every third NST or something and it's reactive, and they're like,
Well, they should do them before they get their dose.
yeah.
Well, that's
assuming they need them.
That's a study set up perfectly, both prospectively and
Been done.
retrospectively.
Been done,
Been
yeah.
done.
We should be practicing evidence-based, and we somehow don't. So the
we
best
have
thing,
only
the best
one
thing to do
study.
is to not order them.
Yeah, there's only one study in the literature comparing buprenorphine and methadone. It's not a very big study. So that's probably worthwhile doing. But if you're going to do them, greater than 4 hours after their dose, or even better, way more than 4 hours after their dose. So that's, people will generally dose at a predictable time. So if they dose in the morning and have their non-stress test in the afternoon, soon you may have an indication. And then withdrawal is another issue. And because the literature is so muddy on the subject, people are withdrawing and they're of a suitable gestational age that probably should be monitored. Not necessarily continuously, but they should be monitored.
Yes, sir.
If there are also in labor,
I would say no. I think you're just asking for trouble. You've got so many other things in labor to go on. The tracing, you have contractions, you can have contraction stress tests, you can simulate the head. There's so many other things you can get information from. So when you're already, the best you're going to get is a 6 if you're doing a biophysical profile. It's still going to put you in, I don't know what to do, category. Yes? No. Sure. Yeah. No, I mean, go ahead. Contribute. Go ahead.
Yes, so basically PPT is an antepartum test. It's not an intrapartum. An intrapartum, we showed in that one study that quoted about giving Servidose causes contraction. At least the Servidose was prostaglandins mediated. You cut down your breathing movement and your body movement. And conversely, indocin, the antiprostaglandin, increases breathing movement. So it's very tightly, breathing movement is very tightly related with prostaglandin. Antiprostaglandins turn them off, turn them on, and prostaglandins turn them off. So much so that people used to do tests of preterm labor to see if they were truly in preterm labor, they would see if they had breathing.
Right.
And there was a correlation that if you had absent fetal breathing movements, you were in true preterm labor, and if you had fetal breathing movements, you were in false preterm labor. But it kind of, there were several studies in that area, but it sort of kind of lost interest. I think it wasn't all that predictive. But there is that correlation. And so it's really I would consider the test of the antepartum test that people love to use, where intrapartum test, we have a lot of intrapartum techniques of, reactivity, variability, stimulation, absence of B cells, I think there's a very tight correlation there.
The study's actually been done on term labor too. That breathing, when the breathing movements are absent, when the breathing movements are present, they're probably in false labor and you can send them home. So that was sort of another. They've done it both in both settings.
And that's sort of those studies done.
So how do you think we should address this hiccup in that our division that has sort of decided that
decided they weren't?
I thought that's good, because I had never counted them before, even though but they are part of the classic definition, so we're not gonna count them, and are we gonna comment on them?
I don't know, and I thought we probably hadn't met it with like a little email thing, and I think the majority of people who responded did not think we should be counting them, and Creasy be damned. So it really is, you know, unreferenced. So it's somebody's idea of adding that in, and it's not. And I never got the articles for you, and I will. It's not in the original description from Manning that hiccups count.
Because the beauty of sort of putting them in there and starting to describe them is that we could potentially look at it.
You could sort of retrospectively or prospectively?
Either way.
Well, if we start documenting this anyway retrospectively versus if we want to do it prospectively, we start an IRB right now.
I mean, but if it's part of our, part of our database, if we start describing them, we can look at it.
I mean, the critical thing is that our text should not be saying, oh, they're hiccuping, therefore they're breathing, and I can give them 2 points. Done, you know, so, and that's the biggest problem.
Should not be teaching us that.
Yeah.
It's not really part of the definition of person later.
No, not.
In all their studies of people too. It's
Correct.
not part of that.
It's not part of the study, but
it wasn't part of the definition. But in terms of counting, I mean, I've talked to some of the older people that used to do those sheep studies all the time. And they basically would say that hiccups is a good sign. I mean, now, that's a
Right.
case reports where you have all kinds of problems, but it's still, I think, in general, I think it's a good sign.
I think, yeah, but knowing its predictive value is difficult. And when does it disappear? I don't know. You know, does it disappear? You know, I don't think we know. We don't know its relationship to hypoxemia necessarily. There's a whole bunch of stuff. You know, how preserved are they? I have no idea. And I think that for that reason alone, we probably should not count them. And I guess that would be my thing, is that we don't know enough about what controls them, and they are not equivalent to breathing movement. And they're easily distinguishable when you measure it. So why? Yeah.
Deployments is
You can find some of the biophysical into what we call fine tone and gross tone. You can't open because people always want to fine tune it more and more. But the basic definition of the biophysical is really
So it's at a score of 7 now?
They actually,
it goes up to 12, both storms early.
when they first designed the biophysical, and a lot of you guys may know this, the intent was to start with a 2-point for each parameter score and then refine it into 1-point categories. But it took off, and they found that they couldn't find cutoffs that were predictive to be able to assign 1 point to this amount of breathing and 2 points to that, or 1 point to this amount of movement and 2 points to that. So it never came. People tried. I mean, the biophysical was just a first attempt at saying, oh, this is a way to assess fetal health, and we're going to do better. And it's been, I was a medical student when that came out. That's how long it's been. I was a medical student because I went through radiology, and that was my student presentation to the group, with the biophysical profile hot off the press. I got to show a video of a biophysical profile, and they had to hunt around for a VCR to show it, you know. But we haven't come any further. Pardon?
Regarding if you have a biophysical, let's say you're not seeing breathing movement, how long will you take the biophysical out to say it's done? Do you quit at 20 minutes, 30 minutes, an hour, 110 minutes, 120 minutes?
Well, that's a good question. I think it depends on what's at stake and how young the baby is. If I'm dealing with a preterm fetus who I really don't think is in trouble, I think bringing it out to an hour is certainly reasonable. and maybe even longer, or reassessing later. If it's the difference between a 4 and a 6, I would and I don't think the baby's in trouble because I have no other good reason. I might repeat it later that day. If it's a term fetus with a 4, who cares? Deliver the baby. So I think both gestational age and what's at stake would be my major, no different than probably anybody else in this room. How do you factor in things? I just at some point you just have to throw in a towel, and you just have to be reluctant at 25 weeks to do that.
Quick question, Dr. Stella. I know how the body movements relate to the NST, but how do the breathing movements correlate with the NST? Variability and acceleration.
I think it has to do more with behavioral state. I don't think they're related at all. When they're sleepy, they're more regular breathing movements, and when they are awake, they have more irregular breathing movements. But it doesn't seem to be relating to the reactivity, as far as I understand. And I don't know the answer for the hiccups because I didn't pull the article. So.
Ultimate insight of fetal activity would be an accidental drop in a GI GoPro during open fetal procedure.
Cool.
And then we can actually see what's going on. Might happen
Do
on
they fit?
accident.
Do they fit down the tube? Put it in there. Oh, that would be cool.
Wouldn't that? I'm just not sure what the IRBs would do.
Hey, is it sterile?
Yes, it's sterile.
Go for it.
A lot of the original studies with fetal behavioral states were done by a guy named Meekes, who was a Dutch guy, and the guy that I trained with would spend time with him in his lab doing. So we actually did some of that stuff when I was at regional during the cocaine years. And the reason to look at it was that some of these drugs, like cocaine and amphetamine specifically, have been demonstrated to cause disorders of neonatal behavioral states. So we were trying to evaluate whether or not they cause abnormalities in fetal behavioral states. So the problem was that we were dealing with a relatively few number of people, and there's so much subjective interpretation that it really it became impossible. We actually got an IRB, but we didn't get any further than that because it was so difficult to operationalize. But given that some of these babies are going to have some problems in the neonatal period, it might be reasonable to sort of try that stuff again.
Yeah, the cocaine, I guess, is a problem because of the metabolite that hangs around for so long in the amniotic fluid. So that's going to be probably make it difficult. But
They're not necessarily active metabolites, though. As opposed to marijuana, that has active metabolites that build up on the fuel.
I think it's kind of controversial.
well, I have to go look back. I have to go back and look at the studies because I cite the slides, but I said and to determine if it's been adequately studied. It may have been exhaustively studied, and I just don't have those in my references. It probably certainly related to the NST. It's probably been studied, maybe not for the biophysical.
Some people would use NST on patients who smoke as an indication of smoking. I see private practitioners that they smoke, report that they're going to go to NST.
They were going to get $2 extra.
I'm not saying it's a good indication, but I'm saying that it has been done. And doesn't seem to rank up to
Black it doesn't.
All right, well, thanks for your attention.
40 people on methadone, and I'm going to
Because you don't want to be wrong. Plus, you're gonna have, check their ballot.